Welcome back to Emergency Chaos, where we provide tips and tricks to help you become the best ER nurse you can be. In this video, we're walking through a chest pain scenario to help you build your critical thinking and decision-making skills in real-world ER situations. Chest pain is one of the most common and high-risk complaints you're going to see. It can be minor or it can be something life-threatening. So let's get started. The case is a 56-year-old male brought in from triage to your room, complaining of chest pain. Now, let's go over what our actions could be. You enter the room and see that the patient is lying in the gurney with the head of the bed elevated. He immediately looks at you, showing that he is alert. There are no signs of increased work of breathing, his skin color is normal, and he is not diaphoretic. Airway, breathing, and circulation all appear stable at first glance on your initial impression. You introduce yourself and begin placing him on the monitor to get a set of vital signs. Vital signs provide very important information. Are they hypotensive, tachycardic, hypoxic, and so forth? While getting them on the monitor, you ask, what brings you to the ER today? Or how can we help you? I like starting off with something like, what brings you to the ER or how can we help you? So that the patient can state in their own words what brings them in without me having to sort of fish around for the answer. And don't forget that starting off with a good introduction and a smile can go a long way. It can even help put your patients at ease. The patient states that he has been experiencing chest pain for 3 days, and it's getting worse. This immediately raises concern, as prolonged and worsening chest pain could indicate a serious underlying condition. You check his vitals, and the heart rate is 109, the respiratory rate is 20, the SpO2 is 95%, temperature is normal, and the blood pressure is a little bit elevated at 162/80, but nothing crazy. You glance at the cardiac monitor and see that he is in sinus tachycardia with no obvious abnormalities on the 5 lead that you have on the cardiac monitor. At this point, you start running through the life-threatening causes of chest pain that you know. These can include like STEMIs, NSTEMIs, pulmonary embolisms, aortic dissections, pneumothorax, and so forth. But you know that the most important next step is going to be obtaining an ECG as soon as possible. Your facility may have protocols in place where you as the RN can order the ECG. So you order the ECG and get started on it. Now, while placing the patient on the ECG lead, you begin asking questions. Assessing and gathering history simultaneously helps save time and ensures you don't miss any critical information. You start with the pain assessment. Where is the pain located? How does it feel? Is it sharp, pressure, burning? Does it radiate anywhere? You ask him to rate it on a scale of 1 to 10 and find out what makes it worse or what makes it better. Does it get worse with activity? Does it get better with rest? Does it get worse with the deep breathing? Next, you assess for risk factors. Has he recently traveled and had a long car ride, increasing the risk for a pulmonary embolism? Does he have any associated symptoms like dizziness, nausea, or shortness of breath? Has this happened before? And if so, what was he told? You also ask about his medical history, current medications, and allergies, paying particular attention for cardiac history and any change in medications. And again, allergies specifically to medications because you may be giving this patient medications. This approach helps ensure that you hit the key questions you need to ask. And now that you've obtained the ECG and send it for review, you perform a quick cardiac and respiratory assessment to gather more information. You already know that the patient is alert without increased work of breathing or diaphoresis. When you saw the EKG, it showed abnormal T waves but no obvious ST changes. But we're waiting for the provider's official interpretation, so you continue your assessment. You ask orientation questions to confirm mental status, then you check peripheral pulses and capillary refill to assess circulation. You palpate for edema, which could indicate heart failure or fluid overload. Next, you listen to the lungs, checking for crackles that could suggest pulmonary edema or for any adventitious lung sounds. Finally, you auscultate heart sounds, listening for murmurs or any obvious extra sounds that could indicate any cardiac dysfunction. This quick assessment helps identify any additional red flags while you await for the further workup. I know that this may all seem like a lot, especially when you're first starting out, but with time, it's going to become secondhand nature to you. You will learn from your preceptor, by watching other nurses, and even from the providers and the type of questions they ask and how they quickly but thoroughly assess their patients. You just have to keep showing up and giving it your best, but with time, it is going to get a lot easier. After this, your preceptor quizzes you. What labs do you think the provider will order and why? For a patient with chest pain, several key labs help guide the treatment and the further workup for the providers. So troponin is ordered to check for cardiac injury, such as with NSTEMI or STEMI. Even without obvious ECG changes, an elevated troponin could indicate myocardial damage. A BNP helps assess for heart failure. A D-dimer is used to screen for possible pulmonary embolism, and if it's elevated, further imaging like a CT angiogram of the chest may be needed. A chemistry panel and a CBC panel provide important baseline information. Electrolyte imbalances such as a low potassium or magnesium can contribute to arrhythmias. The CBC helps identify anemia, infection, or other underlying conditions. These labs, combined with the ECG, the patient assessments, helps the provider narrow down possible causes of the patient's next chest pain and guide the next steps. From here, the next steps depend on the results and the assessments. If the troponin is high, this could suggest an NSTEMI, and the patient would likely be placed on a heparin infusion and monitored for eventual cath lab evaluation by cardiology. If the PNP is high, providers may suspect new onset heart failure and order an echocardiogram and further tests to help assess for heart function. If the D-dimer is high, concern shifts toward pulmonary embolism, leading to CT angiogram to confirm or rule it out. If all initial tests are unremarkable, the patient may typically still be admitted for ACS rule out, where troponin levels in ECGs are repeated over time to help assess for any changes to the EKG or for any troponin levels trending upward. An echocardiogram is also often done, and cardiology may decide to do a stress test or even proceed with a diagnostic cath if there is enough concern. And you know that at this point, continued monitoring and reassessments are crucial to ensure the patient receives the right treatment. Because as we, as nurses, play a critical role in managing chest pain patients. From the moment they arrive, we are the ones continuously monitoring, reassessing, and ensuring timely interventions are carried out. We keep a close eye on lab results, ECG changes, and vital signs, ensuring that any worsening trends are immediately addressed. We assess whether treatments are working. Is the pain improving? Are vital signs stabilizing? Are there any signs of deterioration? Our ability to recognize subtle changes and advocate for our patients makes us essential. If you're finding this helpful and want to save time and energy with mastering the chaos of the ER, check out our book and course. They are packed with everything you need, including foundational material, quizzes, and practical tips to help you feel confident and prepared in the ER. You can also join the channel as a member and gain access to the course by clicking the join button below. You can find the links in the pinned comment and description text below. And as always, teamwork makes the dream work. And here at Emergency Chaos, we are proactive, not reactive.